last topic is the most difficult topic, the myopic disc. The myopic disc is highly confusing in diagnosing glaucoma because many a time they are tilted disc, large disc. So Dr. Vinay Nangia is doing lots of work on the myopic disc in glaucoma. So he is the right person to address this topic. We are privileged to have him here. Dr. Vinay, sir.
Yeah, let's go. Thank you, Dr. Pradeep, and to everyone involved in organizing the conference in Calcutta. I'm delighted to be here. So I'm going to talk to you a little bit about myopia, and I laugh at myself and I say I'm a myopia person, but I'm not really an atropine person, actually. So the prevalence of myopia has varied, and this is a very old slide that I want to. I'm sorry, I don't have a pointer with me. I've requested them to give me a pointer. But if you take a look at the last line, that's the Central India Eye and Medical Study, and it shows that thank you. That's very fine. So Central India Eye and Medical Study, we found a prevalence of more than minus 0.5 diopters myopia in 17% of eyes. However, these were patients that were over the age of 30 and largely over the age of 40 years. And therefore, there may have been some degree of nuclear sclerosis. The current studies in India tell us that the prevalence of myopia in children is about 20% now, and it may increase to 30% in 2030, 40% in 2040, and almost 50% in 2050. But I think we have to wait and watch. Although this tsunami has been predicted, but we want to see how it all goes, and therefore it may be a little premature to predict it right now. What you see on the left-hand side is a graph that shows you that the axial length has got some correlation with the disc area, that as the axial length increases, the disc area increases. But I'm going to come back to you a little bit on that. And the next graph shows you that as the axial length increases, the retinal nerve fiber layer thickness decreases. And I'm going to talk to you a little bit about that also. While the correlation of axial length with disc size does exist, the overall mean disc size may not vary significantly, at least in Central India, and I would like to probably extrapolate it to the rest of the country also. Discs in general may be bigger in high myopes. However, the mean size does not significantly differ between the normal population-based study and what we find in myopia. And all discs in high myopia are not large. That's very important to understand. The correlation of axial length with optic disc was present in the univariate analysis, but did not show up in multivariate analysis for the moderate myopia group. And in the low and high myopia group, there was no correlation in the univariate or multivariate analysis between axial length and optic disc area. So I think that every time we have to look at the optic disc and not worry so much about the axial length, at least in terms of disc size. If you take a look at what's happening here, you'll see that the disc size is about 2.08 millimeters with -8 myopia. And here, let's switch to axial length. With an axial length of 26.6, the disc size is 1.54, and the disc size is 1.41 with an axial length of 27.28. And then suddenly with an axial length of 23.56, which is just borderline, just makes it into the myopia range, you suddenly find that the disc area is 3.95 actually. So you can see that there is a large variation, and just because you have high myopia doesn't mean that you're going to get a large optic disc. The shape of the optic disc tends to evolve, and you can see here on the top left that this is what we call perhaps a normal optic disc shape, and you can see that it's become horizontally oval. Again, it's just oval here, and again, it's slightly tilted and still oval. But you can see that the shape continues to vary, and here it's really different because of the presence of parapapillary atrophy. And I might just tell you that when you have a very large parapapillary atrophy, somehow the disc area tends to be very small in these patients. So the large axial length in myopia often distorts optic disc tissue, both superficial and deep, leading to difficulties in clinical assessment, thus taking away the advantage of comparing with a normal appearing optic disc. So when we're looking at a myopic optic disc, we don't have a reference normal optic disc to say whether there is glaucoma or not. And this introduces a greater variability of the appearance of the optic disc in myopia with or without glaucoma. This is disc pallor. It's very important that disc pallor should be understood for what it is, because we can mistake disc pallor for very shallow cupping, and very shallow cupping and disc pallor need to be differentiated. And this is the right eye of a patient on top here, and this is the left eye of a patient. And you can see the generalized pallor here, and you can see that there is less pallor here compared to the right eye, but nevertheless the disc appears pale. And this is very significant pallor in high myopia. And she had an axial length of 28 and 29 millimeters. The intraocular pressure was normal. And the retinal nerve fiber layer showed significant retinoschisis. So we think that there was, some vascular deficiency, that, the vascular supply was not adequate, and perhaps that would explain why we have disc pallor in such a case. And finally now, the concept of optic disc neuropathy or myopic optic neuropathy is now accepted, and that probably is a good thing. This is a beta zone that is seen in myopia. You can see that the Brooks membrane is reaching up to here, but you can see there is some loss of pigment layer here, and this area is the beta zone. And we need to differentiate beta zone because a lot of optic discs with high myopia, they have got gamma zone, and therefore it becomes necessary in these eyes to distinguish between what is a beta zone and what is a gamma zone. This is an example of tilted disc. It's not necessary that you will get a tilted disc in a patient that has very high myopia. It's a very big range. Neither should you assume that every patient with tilted disc has got significant astigmatism. That was what we were taught, but that's not the case actually. And these are examples of tilted disc in myopic patients, and you can see that tilted discs appear to be very, very small in nature, and that the important thing here is that in some of these tilted discs, where we find it very difficult to diagnose the early and moderate stages of glaucoma. This is a patient with tilted disc and very significant glaucoma, and you can see where the vessels arise, you can see that there is significant pallor here and cupping here, and likewise, in the left eye also there is significant increase in the optic disc cup actually. But these are often very difficult to assess, especially when you have early and moderate glaucoma. But with significant glaucoma, it may not be that hard actually. The other important thing to remember is that there is asymmetricity of glaucoma in myopia, especially when you have large axial length in one eye, that's the left eye here, and you have a somewhat normal axial length in the right eye. The left eye had glaucoma, but the right eye did not have glaucoma. And we know, of course, the risk that myopia is to the development of glaucoma. Now, this is a disc that shows a complete normal distribution of retinal nerve fiber layer. So every time I have a normal distribution of retinal nerve fiber layer in myopia, I thank myself that I'm going to be able to follow up this patient much better than most other patients in myopia, where the retinal nerve fiber layer does not follow the normal pattern actually. So this is a 46-year-old with an axial length of 27.5. The intraocular pressures are absolutely all right. There is a gamma zone here, and you'll see that what's happening is that in this area here and in this area here, there is thickness actually of the retinal nerve fiber layer. And that's because when you get a large parapapillary atrophy or gamma zone, you'll find that the vessels, the angle between the vessel turns to decrease. They tend to come together, and because they tend to come together, it's almost as if they're squeezing the retinal nerve fiber layers together. And also because this retinal nerve fiber layer scan was taken not on the center of the Brooks membrane, but on the center of the optic disc. And so you tend sometimes to get nasal thinning. It's not really nasal thinning, but that's what it appears to be, and that you get thickening of the macular retinal nerve fiber layer, which is actually true to some extent, and that is something that needs to be studied a little bit more. This is again asymmetricity of glaucoma in myopia. The left eye had just very little glaucoma, and the right eye, which was actually a lesser myopic eye, had very significant glaucoma. So I am not able to explain this actually. But this is something that you can get in the odd patient. So myopic discs come in all shapes and sizes. Pallor is exceedingly misleading in the diagnosis of glaucoma and myopia. Normal pressure glaucoma in myopia is extremely difficult to diagnose. High pressure glaucoma may be diagnosed because of either classical or non-classical glaucomatous cupping. And in some patients, the OCT will help in understanding the cause of the possible glaucoma appearance of the optic disc in myopia. There is great variation in the retinal nerve fibular thickness in myopia. Besides the axial length, there are other parameters that influence the RNFL thickness, and that includes the size of the optic disc, presence of gamma zone, centration of the RNFL circle, pattern of vascular origins from the optic disc, and possible asymmetric changes in the axial length of the eye. Thank you all very much.
Thank you very much, sir. It was wonderful. Who has the next course in this hall? Oh, okay, you are here. So we hardly have any time. So the next team is ready to take over. Thank you very much for coming and attending this instruction course.